everybody. This is me, Ahmed Magdy Mustafa, Lecturer of Cardiology, Military Medical Academy. Today the talk is about chronic coronary syndrome in a special population. Firstly, the management of chronic coronary syndrome in the presence of cardiovascular comorbidities. And the first cardiovascular comorbidity is hypertension. Regarding the European Society of Cardiology definition of hypertension, the office blood pressure should be over 140/90, and in the old age over 80 years of age, the blood pressure should exceed 160/90. Regarding the recommendations for hypertension treatment in chronic coronary syndrome, it's recommended that the office blood pressure to be controlled to target values 120 to 130, and in general, and in systolic blood pressure for blood pressure 130 to 140 in older patients who are aged more than 65 years. This is class 1A recommendations. In hypertensive patients with recent MI, beta blockers and RAS blockers are recommended. In patients with symptomatic angina, beta blockers and or calcium channel blockers are recommended, and this is class 1A indication. The combination of ACE and ARB is contraindicated. Regarding the treatment of chronic coronary syndrome in patients with valvular heart disease, including those who are planned for TAVR, invasive coronary angio is recommended before valve surgery, and especially in the presence of history of cardiovascular disease, suspected myocardial ischemia, systolic dysfunction in men and in men over 40 years of age, and postmenopausal women. Invasive coronary angio is recommended in the evaluation of moderate to severe functional mitral regurgitation. Coronary CT angio should be considered as an alternative to coronary angio before valve intervention in patients with severe valvular heart disease and low probability for coronary artery disease. Lastly, PCI should be considered in patients undergoing TAVI and coronary artery diameter stenosis more than 70% in proximal segments. In severe valvular heart disease, stress tests should not be routinely used to detect coronary artery disease because of the low diagnostic yield and potential risk. Regarding the non-cardiovascular comorbidities, firstly, the patients with cancer, the treatment decision should be individualized according to many factors, and if revascularization is indicated in highly symptomatic patients with active cancer and increased virility, the least invasive procedures is recommended. Regarding patients with diabetes mellitus confers about twofold increased risk for cardiovascular disease and coronary artery disease, so control of risk factors is recommended for the prevention of cardiovascular disease. Systolic blood pressure in patients with diabetes should be targeted to below 130/80. For the majority of patients with diabetes and coronary artery disease, a targeted glycated hemoglobin below the level of 7% is recommended. In asymptomatic patients with diabetes, a periodic resting ECG is recommended for cardiovascular detection of conduction abnormalities, atrial fibrillation, and silent myocardial infarction. ACE inhibitors is recommended in chronic coronary syndrome with diabetes for event prevention. The SGLT2 inhibitor like empagliflozin, canagliflozin, or dapagliflozin are recommended in patients with diabetes and cardiovascular disease. A glucagon-like peptide 1 receptor agonist is recommended in patients with diabetes and cardiovascular disease. In asymptomatic adults aged over 40 with diabetes, functional imaging or coronary CT angiography may be considered for advanced cardiovascular risk assessment. Regarding patients with chronic kidney disease, there is a linear increase in the risk of cardiovascular mortality with decreasing GFR. Special attention during the workup for chronic kidney disease patients with suspected obstructive cardiovascular disease should be paid to the fact that angina is less common and silent ischemia is more common. Additionally, non-invasive stress tests show reduced accuracy in patients with chronic kidney disease. The recommendation of the European Society of Cardiology for patients with chronic kidney disease is recommending the tight control of all risk factors. It is recommended that special attention is paid to the potential dose adjustment of renally excreted drugs used in chronic coronary syndrome and it is recommended that the use of iodinated contrast agents is minimized in patients with severe chronic kidney disease and preserved urine production to prevent further deterioration of the kidney functions. Regarding the age and sex, elderly patients who are aged over than 75 years have the greatest mortality and morbidity risk attributable to chronic coronary syndrome, which is enriched by the high prevalence of comorbidities. Elderly patients often present with atypical symptoms which may delay the proper diagnosis. The treatment of chronic coronary syndrome in the elderly is complicated by a higher vulnerability to complications for both conservative and invasive strategies, such as bleeding, renal failure, and neurological impairments. Regarding women who have higher complication rates following CABG and may also have higher mortality risk, especially in elderly patients. It's recommended that particular attention is paid to the side effects of drugs, intolerance, and overdosage in elderly patients. The use of drug-eluting stents is recommended in the elderly population. The radial access is more recommended in the elderly patients to reduce access site bleeding complications. It's recommended that the diagnostic and revascularization decisions are based on symptoms, the extension of ischemia, virility, life expectancy, and comorbidities. Finally, the hormone replacement therapy is not recommended for risk reduction in postmenopausal women. Lastly, regarding the patients with refractory angina refers to long-standing symptoms for more than 3 months. Lastly, in patients with refractory angina refers to long-standing symptoms for more than 3 months due to established reversible ischemia in the presence of obstructive coronary artery disease, which cannot be controlled either by optimal medical treatment, PCI, or CABG. The enhanced external counterpulsation may be considered for symptom relief in patients with refractory angina to optimal medical treatment and revascularization strategies, and this is class 2B recommendations. Spinal cord stimulation may be considered to ameliorate symptoms and the quality of life in patients with debilitating angina, refractory to optimal medical treatment and revascularization strategies, and this is also class 2B recommendations. Thank you and hope it is a fruitful lecture.